Hi everybody, and welcome to our module on psychotic disorders. Psychosis refers to a loss of perception of reality, and you can see psychosis in both medical and psychiatric disorders. For example, patients who have delirium can experience psychosis, and then in psychiatry, schizophrenia is the classic psychotic disorder that we'll talk about later in this video. People can also develop psychosis if they have taken certain drugs, either illicit or prescription. This is called drug-induced psychosis. And there are three main manifestations of psychosis. They are delusions, disorganized thoughts, and hallucinations, and we'll go through each of these in the next few slides. Delusions are strongly held beliefs that conflict with reality. A patient who is having a delusion can usually not be talked out of it. They are sure it's true, no matter what you tell them to the contrary. And you can break down delusions into different forms. A patient with persecutory delusions might believe someone is after them. A patient with grandiose delusions could believe they are a millionaire, even though they are not. Erotomanic delusions are delusions that someone is in love with you who obviously isn't. For example, Brad Pitt is in love with me would be an erotomanic delusion. Somatic delusions are delusions involving feelings about the body. So someone who thinks there are worms on their chest when there are not could be having a somatic delusion. Delusions of reference refer to delusions where people think other things that are happening in the world are about them. For example, someone who thinks the television newscaster is talking about me, or certain events in the world are occurring because of me. Those are delusions of reference. And then finally, delusions of control are where somebody thinks either they are controlled by others, like my body is controlled by aliens, or they think they can control things that they cannot, like I can control the sun. Second element of psychosis is disorganized thought, and this usually presents as abnormal patterns of speech. There are multiple different patterns of speech that can be evidence of disorganized thought. One of them is alogia. This refers to speech poverty. Patients with alogia say very few words and are not very talkative at all, and this can be an element of psychosis. Patients with thought blocking will suddenly and abruptly stop in the middle of a sentence when they are talking, and you can see this in patients with psychosis. Patients who have loosening of association display speech where the ideas they're discussing do not follow one another, so they will speak about disconnected or fragmented topics that don't obviously relate to one another. Tangentiality is somewhat similar. In this problem, patients diverge from one topic under discussion to another very quickly, so they go off on tangents. The topics may be loosely related, but the patient is not able to stay on one topic and stay focused. That's tangentiality. Other elements of disorganized thought are clanging. This is using words that rhyme but don't make sense. So, for example, a patient with psychosis who is clanging will say things like, "The cow said how, he had to bow." Word salad refers to using incoherent words that make no sense. And perseveration refers to repeating words or ideas persistently. And hopefully in your clinical rotations you get to meet some patients who are actively having psychosis. Once you do, all these things become very easy to understand because you will see that these patients have very abnormal speech patterns, and that's because their thoughts are disorganized. And then the last element of psychosis is hallucinations. Hallucinations are sensory perceptions that occur in absence of external stimuli. Visual hallucinations refers to seeing things that are not there, and this is very common in hospitalized patients who have delirium. They often see people or things who are not in the room. And in general, visual hallucinations are often due to an organic cause, meaning they are not caused by a psychiatric disorder. You can see visual hallucinations in patients who have delirium, in patients on certain drugs, and in patients with central nervous system diseases. Auditory hallucinations are hearing voices or sounds that are not present, and this is a classic feature of schizophrenia, which we'll talk about later, and auditory hallucinations often occur in psychiatric disease. Besides visual and auditory hallucinations, which are the most common forms of hallucinations, patients can rarely have hallucinations involving other senses. For example, olfactory hallucinations involve smell, gustatory involve taste, and tactile hallucinations involve sensations like bugs crawling on the skin. Now that we understand psychosis, we'll talk about specific psychotic disorders, and the first one we'll discuss is schizophrenia. Schizophrenia is a chronic psychiatric syndrome in which patients have recurrent episodes of psychosis, along with cognitive dysfunction and what's known as negative symptoms, which we'll talk about in just a minute. The underlying pathology of schizophrenia is better understood than many other psychiatric disorders, so let's talk about that now. It's been clear for many decades that excess central dopamine activity is associated with schizophrenia. And the reason we know this is because antipsychotic drugs that are dopamine antagonists are helpful for therapy in schizophrenia and improve the psychotic symptoms. The other thing that is well established is that hypofunction of the NMDA glutamate receptor is also very common in patients with schizophrenia. This doesn't have any bearing on diagnosis or therapy, but it's well described in the literature. The NMDA receptor binds glutamate, and it's hypofunctional in patients with schizophrenia. Another piece of evidence for the biological basis of schizophrenia is that by MRI or CT, you can find lateral ventricular enlargement in patients who have schizophrenia. If you look at this image on the screen, the image on the left is from a patient who does not have schizophrenia. The image on the right is from a patient who does have schizophrenia. And hopefully you can see that the lateral ventricles, which are at the tips of the red arrows, are larger in the patient who has schizophrenia. Also among patients with schizophrenia, if you do a PET scan, which is a type of scan that allows you to identify activity in various regions of the brain, you will find underactivity in the frontal lobe of patients who have schizophrenia, and you will find hyperactivity in the basal ganglia. Now, how exactly the activity of the frontal lobe and the basal ganglia and the NMDA receptor come together to cause schizophrenia is not well understood. But the evidence for a biologic basis underlying schizophrenia is very strong and much stronger than in many other psychiatric disorders. Let's talk about the epidemiology of schizophrenia. The lifetime prevalence is about 1% of all adults globally. It has a slight male predominance, and it usually has its onset in adolescence or young adulthood. In men, it's age 18 to 25. In women, it's a little bit older, 25 to 35. For reasons that are not well understood, schizophrenia is more common in people who live in urban areas, meaning cities. It's also more common in people who immigrate to cities. There was a UK study which found that immigrants into England were 10 times more likely to develop schizophrenia than people who are non-immigrants. Babies who are born to mothers who have certain obstetric complications at the time of delivery are more likely to develop schizophrenia. So when the mother has something like hemorrhage or preterm labor, or mismatch of blood groups, or fetal hypoxia, or maternal infection, these things are all associated with slightly higher risk of the baby developing schizophrenia. Use of cannabis, meaning marijuana, especially in adolescence, is associated with a higher risk of schizophrenia. It's unclear if this is a cause and effect phenomenon or whether mild symptoms in adolescence lead to more cannabis use. But nevertheless, among cannabis users, there is a slightly higher risk of developing schizophrenia. So patients with schizophrenia have recurrent episodes of psychosis, but let's talk about what exactly those episodes look like. In terms of hallucinations, the main manifestation is auditory hallucinations. Patients with schizophrenia often hear voices and strange sounds. These are classic elements of the psychosis of schizophrenia. Patients with schizophrenia also have delusions. The delusions can really run the gambit of all the types of delusions that we talked about before. Schizophrenia patients also have disorganized speech as an element of their psychosis. Most commonly, it's tangential or circumstantial speech. So as we talked about earlier, patients with tangential speech change topics very frequently, and they may not answer your questions because they quickly move from one topic to another. And then circumstantial speech is where patients give long, roundabout answers to questions. So like I told you before, one element of schizophrenia is recurrent episodes of psychosis. The second element is cognitive impairment. Patients with schizophrenia have difficulty processing information, they have trouble paying attention, and in general they have poor learning and memory. The symptoms of schizophrenia are divided into negative symptoms and positive symptoms. The positive symptoms are the abnormal behaviors of schizophrenia associated with psychosis. So these are things like hallucinations, delusions, and disorganized thought. These symptoms are generally related to excess dopamine activity in the brain, and they usually respond well to antipsychotic drugs that block dopamine activity. The negative symptoms of schizophrenia, on the other hand, are symptoms that revolve around an absence of normal behaviors. So for example, many patients with schizophrenia have a very flat affect and an expressionless face. These patients tend to speak very little and use few words. This is poverty of speech or alogia, like we talked about earlier. Patients with schizophrenia have trouble engaging in social interactions. This is called asociality. They also lack motivation and can't complete tasks. This is called avolition. And patients with schizophrenia also often cannot feel pleasure. This is anhedonia. So all these symptoms are called the negative symptoms, and they are harder to treat. They often persist despite therapy. They will sometimes improve on certain antipsychotic drugs, but they are harder to treat than the positive symptoms. Schizophrenia carries a high risk of suicide. 5% of all schizophrenics commit suicide, and 10% of all suicides occur among patients who have schizophrenia. The diagnostic criteria for schizophrenia require at least 1 month of 2 or more of the following symptoms: delusions, hallucinations, disorganized speech, disorganized or catatonic behavior, and negative symptoms. So you must have 2 or more of these, and one of the 2 must be delusions, hallucinations, or disorganized speech. You cannot make a diagnosis of schizophrenia with only the last two elements shown here. You must have one of the first three. And then in addition to 1 month where two or more of these elements are present, you must have continuous signs for at least 6 months. So maybe you don't always have two or more of these 5 elements present, but you have some elements of schizophrenia that are ongoing for 6 months. The treatment of schizophrenia is with antipsychotic drugs and psychotherapy, and I talk in detail about antipsychotic drugs in another video. If you have a patient that meets criteria for schizophrenia, but the duration of symptoms is only 1 to 6 months, then that patient does not have schizophrenia. That patient has schizophreniform disorder. You can think of this as a mild version of schizophrenia that is of short duration and not a chronic disorder like schizophrenia. And make sure you know this 1 to 6 month time length. The boards like to emphasize this diagnostic criteria. Next, let's talk about brief psychotic disorder, which is even milder than schizophrenia and schizophreniform disorder. In brief psychotic disorder, a patient develops psychotic symptoms only. There's no cognitive impairment, there are no negative symptoms, there is only psychosis in this disorder. It has a sudden onset and a full remission within 1 month. It's more common in women than men, and it commonly follows a stressful life event, like the death of a family member or the loss of a job. One of these things will happen, and the patient will develop elements of psychosis. The symptoms will resolve within 1 month. That's brief psychotic disorder. Some patients have schizophrenia symptoms along with symptoms of mania and depression. When this happens, there are two diagnostic possibilities. The first one is that the patient has schizoaffective disorder. This is schizophrenia along with mania or depression. In order to meet criteria for schizoaffective disorder, the patient must have some episodes of psychosis alone. And by this I mean some psychosis must occur in absence of any symptoms of mania or depression. The DSM-5 requires 2 or more weeks with psychosis features alone in order for a patient to be diagnosed with schizoaffective disorder. The second possibility when a patient has symptoms of schizophrenia along with symptoms of mania and depression is that the patient actually has mania or depression with psychotic features. When this is the diagnosis, all the psychotic episodes will occur at the same time as symptoms of mania and depression, and there will not be any episodes of psychosis that occur alone. So here I've shown a couple of months along the x-axis of this slide, and I've shown a possible course of what schizoaffective disorder might look like. So the patient could have psychotic symptoms that run throughout this 6-month period, but only during 2 of the months do they have symptoms of mania and depression. Note that there are lots of periods, like here, where the patient is having psychosis without mania or depression, and therefore this patient's diagnosis is schizoaffective disorder. In contrast, a patient who has a mood disorder like mania or depression with psychosis will have a possible course like what I've shown on this slide. So there will be multiple episodes of mania or depression, and one of them, which is a particularly bad episode, has psychotic features. Note that on this time scale, there is never an episode of psychosis alone. Therefore, the diagnosis here is a mood disorder with psychosis. Make sure you understand this distinction. The boards will definitely ask you to distinguish between mood disorder with psychosis and schizoaffective disorder. The last disorder we'll discuss is delusional disorder. In this disorder, a person develops 1 or more delusions that last a month or longer, but they otherwise have no abnormal behavior and no evidence of psychosis. So for example, imagine if a man believes he's being followed for the past 2 months, he frequently checks for someone behind him, he cannot be persuaded he is safe because he has the fixed false beliefs of his delusion. However, he otherwise has no hallucinations, no disorganized thought, no negative symptoms. He does not meet criteria for schizophrenia or schizophreniform disorder. This man has a delusional disorder. Rarely, delusional disorder can lead to what's known as folie à deux, which is the madness of two. This is where a close friend or family member shares the delusions. Usually one person develops the delusions and is so persuasive and dominant over the other person that the delusions are passed on and the two people have identical delusions. This is a very rare but fascinating psychiatric disorder. Classically, if you get the two people in different rooms and interview them, the person who is not the dominant person will have their delusional symptoms quickly resolve. I'll finish with this one table summarizing the things you want to remember about psychotic disorders. Remember that schizophrenia and schizophreniform disorder have the 3 elements of psychosis, learning disability, and negative symptoms. In schizophrenia, they last longer than 6 months. In schizophreniform disorder, they last 1 to 6 months. Brief psychotic disorder is only psychosis, and it lasts less than a month. Delusional disorder is only delusions, and it lasts more than a month. And then lastly, remember what we talked about in terms of schizoaffective and mood disorder with psychosis. It all depends on whether the psychosis occurs alone or always in the setting of mood symptoms. And that concludes our module on psychotic disorders.